The following is the testimony of Dan Cross, Executive Director for the Absentee Shawnee Counseling Services and Chairman of the Media and Public Relations Committee of the Oklahoma Association for the Treatment of Opioid Dependence at the Public Health Committee hearing on painkiller addiction crisis in Oklahoma in the fall of 2012. The problem that we are facing with prescription painkiller addiction looks alarming, but what we have seen is only the tip of the iceberg. The worst is yet to surface. Why I say that is couched in the very nature of the disease of opioid addiction. First, we need to understand that opioids are a class of drug known as analgesics. They numb the pain receptors of the brain. Now, what this does is when the drug wears off, it produces a rebound effect, a hypersensitivity. For chronic users, that hypersensitivity becomes chronic also. Now, why that is important is they affect the pain receptors, the person's perception of pain, both physical and emotional. And the reason that is because the pain receptors signal to the pituitary and hypothalamus glands to decrease its production of endorphins. Endorphins are opioid peptides, natural opioids in the body that not only affect one's perception of physical pain, but affect their emotions as well. So what happens is when a person becomes chronically hypersensitive to both physical and emotional pain, this sets up a situation where they're becoming treatment resistant. As their tolerance to the drug increases, so does their chronic hypersensitivity and the resistance to treatment. And we will see in a minute that treatment resistance has borne out statistically as well. Now, when you couple that with the sheer number of people that are affected, it creates a huge problem. Oklahoma actually leads the nation in prescription painkiller addiction. In March of 2008, SAMHSA, the Substance Abuse and Mental Health Services Administration of the Department of Health and Human Services, announced that in Oklahoma, 6.7% of people 12 and older abuse prescription painkillers. That statistic was extremely alarming. They came back in March of 2011 and stated that prevalence had grown to 8.13%. And that 8.13% is nearly doubling the national prevalence, the national average. And the alarming thing is that Oklahoma appears to be pulling away from the rest of the nation. So we've got an epidemic on the national level, but Oklahoma is pulling away, far outpacing the rest of the nation. This is quite alarming. So just how big is it? Well, back in 2006, the Oklahoma Bureau of Narcotics and Dangerous Drugs estimated about 87,000 people in Oklahoma were painkiller addicts. Now, when they classified them as addicts, they're saying that they had gone past the abuse level, that they were hardcore addicts. Many of the agents actually questioned whether that was being too conservative. We know that painkiller abuse has skyrocketed since 2006. I have not been able to find a current figure for that number. But we do know that 8.13% of Oklahomans abuse painkillers, according to the latest SAMHSA projection. So that would involve over 245,000 Oklahomans. Now, how this statistic appears, Centers for Disease Control graphic that came out back in November of 2011 would be very helpful for us to kind of get an idea, wrap our minds around how this appears to us public. First, you see here on the structure, you've got the one purple figure at the top that represents opiate related or prescription painkiller related deaths. And for every one of those, there are 825 non-medical users that are signified by the light baby blue colored dots at the bottom. Now, the red dashed line signifies the surface. When we begin to see these people, and as you can see there, 32 of the 825 are accessing our ERs, our emergency rooms, for the purpose of medication seeking. So this drug seeking behavior makes them visible to us. We begin to see them because of this. And of the 825, only 10 are seeking treatment admissions for prescription painkiller abuse. And of that 825, of course, one painkiller related death. So this is why I say we are only currently seeing the tip of the iceberg. There's a whole vast mass of people out there that are in some stage of abuse, of an addiction that is progressive. Unless there is some type of intervention, we can expect them to be fully addicted, hardcore addicted, and surface at some point in time. Now let's take a snapshot in time here. This light blue triangle, right triangle that on its side, it represents the 245,000 abusers in Oklahoma. The axis on the bottom, labeled demand side effective treatment, that represents the progression of the addiction, and we see that red arrow, that's a pipeline headed towards addiction. So we see 245,000 abusers. Now, some of those abusers will be able to quit on their own. Some will go into traditional forms of treatment, substance abuse treatment, which involves inpatient detox and then outpatient or intensive outpatient, whatever, and they will stay quit. Now, we will get those statistics in just a moment, but a large portion of those are going to need specialized treatment. Definitely the ones that are hardcore addicted will need specialized opioid treatment programs. Now, the 100,000 there, where do I get that? Well, I look at, and this is only my personal estimation, I look at the 86,000 addicts that the Oklahoma Bureau of Narcotics identified back in 2006, and I think it's reasonable to believe that that has grown to at least 100,000 by 2012 at the rate that we've seen the abuse increase. And so that leads me to believe that we have at least 100,000 people that are going to need the specialized opioid treatment program treatment. But the truth is that we only have 3,700 people currently in the state that are accessing opioid treatment program care. So we have a referral problem, and referral channels do not lead to the most effective treatment, and we'll address that of course in just a moment. What we see here is that most of the people are being referred to traditional treatment, which has been ineffective. So who is addicted? Well, the people that are addicted are not the typical people that we think of when we think of addiction, especially heroin addiction. Heroin is the typical opiate addiction that we think of, and so we think of these people that are in flop houses with long stringy hair, etc. But as we see by the pictures of the people here, the celebrities, that this picture has changed. Indeed, Rush Limbaugh does not fit that picture whatsoever. The wife of the Oklahoma County DA several years back was a practicing physician, a well-respected physician. She now is helping other physicians who are drug addicted. So, proves that help is possible for these people. But what we have here are the young and internet savvy, along with the elderly and the chronic pain patients that are becoming addicted to opiates because of these prescription painkillers. Now, why this is a problem is we have done a great job responding to shrinking the supply of these drugs that are on the street. It's taken a while. It's taken some fine-tuning, but our law enforcement has really done a great job, and they're getting more and more cooperation from physicians and pharmacies, and so we are shrinking the supply. It started back in 2003. President Obama came out in April of 2011 with a plan. I applaud that, but that plan focuses almost entirely on the supply side, shrinking the supply that hits the street. There's a little bit of provision for prevention, but there's nothing about treatment whatsoever. Now, why this is important is because we have how many? 245,000 prescription painkiller abusers in Oklahoma. What's going to happen to them? To start that discussion, I want us to look at what is the result when people get desperate, when they can't find supplies of their opiates and they are addicted. Now, I've identified a projection, my personal projection of 100,000 people that are hardcore addicted. What happens when they suddenly become sick and desperate? What does that look like? Well, you see the story of a man falling out from a building here in what appears to be a hospital room. The story behind that is this was the photo that was taken of a prominent Oklahoma City attorney. It was above the fold. It was a headline story in the Daily Oklahoman in July 27th of 2006. Now, the story behind this is that I think it might have been the day before. This attorney went into a pharmacy and at gunpoint held up that pharmacy to obtain OxyContin. He received a large bottle of those pills, and he was so desperate that he did not flee the scene. He sat down on the floor of that pharmacy, opened up the bottle, and began to eat those pills when the police came in and arrested him. He went to jail where he attempted to commit suicide. This is desperation. He did that by jabbing a pin into his neck. He missed his jugular vein, fortunately, so they took him to the hospital. Here he is pictured having jumped out of a hospital window where he landed on it was a fifth-story window, and he landed on a two-story roof 3 stories below him. So, fortunately, that is the picture of desperation. Opiate addiction is the most powerful addiction. Yes, methamphetamine is destructive. The other addictions are destructive. Alcohol kills more people than any other drug. But there is no addiction that is more powerful than opiate addiction in terms of withdrawals and after withdrawals, the persistent cravings that occur, and that creates desperate behavior. This type of addiction requires a different treatment. Traditional substance abuse treatment, according to SAMHSA, has been 8 to 10% effective. That means 90 to 92% of the time, these people did not get better. They went right back to using. There is a SAMHSA evidence-based best practice. Their research across the country, thousands of different programs, they have identified medication-assisted treatment, which they have put into manual form as a model, Treatment Improvement Protocol 43, and it has 70 to 75% positive outcomes. That is 9 times better than traditional treatment, and it skips inpatient detox. Now, why that's important is inpatient detox serves as a bottleneck, and at any given time in Oklahoma, we'll have a waiting list of 1,000 to 1,300 people waiting to get into an inpatient detox or residential treatment setting. And here's the dilemma. You're a case manager of one of these, you're a counselor of one of these people, and finally they're ready to get help. And so you call up and you've got a month waiting list. I'm going to ask you, where are they going to be in 1 month? Will they still be ready for help in 1 month? What kind of damage will have occurred in 1 month? Will they even be alive in 1 month? Now, what happens is there's a continued destruction in their person, in their circumstances, and when when you reach this point, often that it is accelerating at a quite rapid pace. And so what we want to do is we want to get them directed to the correct treatment, the most effective, cost-effective treatment, in order to keep all of the stabilizing support structure in place for long-term best outcomes. Another thing that is very concerning is that heroin has become an alternative supply to the supply crackdown on prescription painkillers. We may not have anticipated that, but the Mexican drug cartel has. Heroin is cheaper, it's purer, and it's more prevalent than it's ever been before. ABC News 2020 did a series called The New Face of Heroin Addiction. The theme of that series is that the people that are becoming heroin addicts today are people that you would have never suspected. Indeed, they would have never dreamt that they would be heroin addicts. These are people that were living one kind of life before and are now sticking a needle in their arms. Now, why this is dramatically important is because of the criminal activity that is associated with heroin addiction. The Oklahoma Department of Mental Health and Substance Abuse Services says that 5% of substance abuse treatment admissions are heroin addiction. On the other hand, that represents about 26% of our criminal justice population. So there is 5 times the prevalence of criminal activity associated with heroin addiction. So this brings us to the progression of painkiller addiction and the related consequences that affect the community, the ripple effect, so to speak. What happens is they're cruising along, and that yellow line there that takes the dip, the flattened part on the left, represents people cruising along in their prescription painkiller addiction. They're able to maintain their addiction and sort of maintain their lives in somewhat a sense of normalcy. Then they can't get their drug, or the drug becomes scarce. And so what happens is they start calling in sick because they are desperately sick. Spend their time instead searching for supplies and running around doing all sorts of things trying to find a supply of drug. And so they lose their jobs. And if you lose your job, what happens to your ability to pay the rent? You lose your home. And if you lose your home, what happens to the family? So child welfare gets involved. And all of that drama, unnecessary pain, and the criminal justice system becomes involved, and ultimately they lose their health. And so when we find a person that has reached the bottom of this, I've actually directed teams, outreach teams that have intervened at this level of homelessness and where all this destruction has occurred, and we have to amass very intensive care in several different domains, and those interventions require a matrix of intensive services that are expensive. They're not cost effective, and we have very poor outcomes. We rarely get people back to anywhere near where they were functioning before. But instead of going down this trough, medication-assisted treatment, if they are referred at the right point in time, we can skip inpatient detox, that waiting list, skip all of this destruction, and people go right into outpatient treatment where they're maintaining their employment, maintaining their home, and we have 75% effectiveness rates. In our particular program, in the first 6 months of 2012, we had an 86% effectiveness rate. So what we're saying here is is we have an answer to Oklahoma's painkiller addiction crisis. This is a crisis. We haven't seen it in its fullness yet. The mass of it has not yet surfaced. But there is an answer. What do we need? Well, we need a strategic community responses. We need early detection and intervention. We need to be able to understand and know the warning signs of prescription painkiller addiction. I've written some articles and made some videos that are online that raise public awareness of that. We need to inventory our opioid treatment programs that are available in our respective areas, and you can find those at this webpage URL that is on the slide here. Not all the opioid treatment programs are the same, so if you go to our website you can find a checklist for superior opioid treatment programs. So this gives you the questions to ask to identify which ones are the best. And then you can identify all the wraparound services that are necessary in anticipating barriers to treatment. That would include transportation, child care, all of those type of things. And then catalog all the above services with access and requirements so that they're easily identified pathways that we develop to treatment. We make it easy as possible to get them to the right, most cost-effective and most effective treatment available. And then we get this information to first-tier responders. Who are first-tier responders? That would be people like doctors, it would be nurses, churches, people like social service agencies, agencies where people go to when they need help, schools, all sorts of people like that. These are our programs, the Absentee Shawnee Counseling Services in Oklahoma City and the Katua Cherokee Treatment Services in Tulsa.